Onc Live Insights is a video editorial program produced by Onc Live.
The current modality for imaging includes both anatomic cross-sectional imaging, most commonly CT scans or MRI. CT scan often recommended to be done in a multiphasic way, and MRI often can be a little bit better for the liver tumors. In addition to this, nuclear imaging is often done as well. This can give us a more global view of what's going on with these tumors and can also provide rationale for a certain type of treatment. PET, FDG PET is actually not found to be terribly helpful in this group of tumors. What is really used is really somatostatin receptor-based imaging, such as octreoscan scan. And these tumors, I would say over 70% of them will light up on octreoscan scan and tell us both about the locations of the tumors and also whether somatostatin receptors are present on them. In the past, ultrasound has also been frequently used, although I think at these days, CT and MRI are generally preferred.
For pancreatic neuroendocrine tumors, as in any cancer, the sort of workhorse scans are conventional cross-sectional imaging, CT scans and MRIs, except that when it comes to liver metastases, which are the predominant metastases, we typically use multiphasic imaging. So for CT scans, it's three-phase CT with arterial phase, venous phase, and non-contrast imaging. For MRI, we often use EUVIS contrast to better delineate the liver metastases. Octreoscan is a scintigraphic image that's been available for many years. It images somatostatin receptors, and it's quite useful, especially for well-differentiated tumors. But there are more novel imaging techniques, such as gallium-68, dotatate or dotatalk PET scans, which basically also image somatostatin receptors, but with much higher resolution and higher sensitivity than octreoscan. Those are widely available in Europe and probably will be more prevalent in the United States in the near future. When we see a pancreatic neuroendocrine tumor for the first time, if the tumor is non-metastatic, we typically consider surgery. Resectability criteria are similar to those of adenocarcinoma. In other words, making sure that the tumor doesn't involve major arteries such as the celiac artery, superior mesenteric artery, major veins such as the portal vein or superior mesenteric vein in a significant fashion. We sometimes wonder, though, about small, incidentally detected tumors that are increasingly found as patients undergo imaging modalities for other reasons. When we're dealing with those tumors that can be pathologically diagnosed with endoscopic ultrasound and fine needle aspiration, the natural history can often be quite indolent. And in many cases, if the tumor is smaller than, say, 2 centimeters or 1.5 centimeters and the patient is completely asymptomatic and the histology is consistent with a low-grade tumor, we often talk about active surveillance as an option rather than surgery. This is true especially for older individuals and/or individuals with significant comorbidities. For patients with metastatic disease, we sometimes also consider surgery, and the circumstances are patients with relatively few metastatic tumors that can be surgically resected. And the criteria for resectability often is if at least 90% of disease can be either resected or ablated, although it's important not to be too dogmatic about that 90% number. There are cases where a very large symptomatic tumor should be resected even if remaining disease is more than 10%, whereas there are other cases where a surgeon could technically ablate a lot of small tumors in the liver, but the benefits of that approach might be questionable. The question of cytoreductive surgery for patients with neuroendocrine tumors is one that's often considered at the very first presentation, although there are some cases where the disease can be approached neoadjuvantly with regimens that can actually shrink tumors, such as cytotoxic chemotherapy, with the goal of eventually proceeding to surgery afterwards. In some cases, patients will be started on somatostatin analog. Disease will be stable, and at that point, be referred to a surgeon to consider debulking surgery.
If a patient has a tumor that has not yet metastasized, the first question is always, can it be taken out surgically? Surgery is the only way to cure a patient with a pancreatic neuroendocrine tumor at this point. Because of the location, sometimes when these tumors grow, they can get very close to blood vessels or involve nerves, and that can make surgical resection difficult. There are some treatments that can shrink pancreatic neuroendocrine tumors. Most of those treatments right now are chemotherapy. So there has been an idea, at least, that if you treat a patient ahead of time, you might be able to shrink the tumor down. I would have to say there are very few studies that have looked at this, so it's not a proven approach, but it's something that we will certainly sometimes try.